I'm back.
Welcome, everybody, to Perfecting PT. Today, we're joined by Sean Harris and apparently also my home heating unit. Apparently, my our heat wanted to get involved with these cold Colorado days. So we're joined by Sean Harris, and I'll just kind of let him introduce himself. But just know the topic for today generally, and Sean's going to let us know a little more about this, is spinal stiffness and kind of the research around it currently from kind of his views and how he's using it.
Yeah. Thanks, Nate. Appreciate you having me on here.
Absolutely.
My name's Sean. I went to graduate school for the first time here in Houston. I graduated from Texas Women's University, their physical therapy program there in 2015. I went and did a orthopedic residency program with Memorial Hermann, which is one of the big hospital systems here in Houston. And I graduated from there and then stayed on with them on faculty. I worked there for about 8 years or so, different roles in teaching the residency, and I taught some of the curriculum, did mentorship, all that kind of stuff. I did my fellowship here in Houston, so I have a fellowship in manual therapy through Optum, which is a privately owned PT manual therapy fellowship here in Houston. And then I also went and I got my PhD from Texas Women's University also, and all of my research emphasis was on low back pain, kind of specifically centered around the decision-making standpoint in terms of who gets surgery and who doesn't. And I guess kind of to give a picture of what I do on a daily basis. So I own a couple of businesses. I own a gym. I own a pickleball business. I own a physical therapy business that's inside of my gym. And I also own Ignite Clinical Institute, which is a CCU company. So even though I kind of have a couple different hats, I guess you would say, I've kind of built the facility where I can pretty much do everything out of there. So the topic that we're going to kind of talk about today under spinal stiffness actually centered around my own kind of personal interest in weightlifting and seeing patients with back pain while they were weightlifting and kind of figuring out better ways to assess. So for the last couple of years, since I've been fully on my own and doing my own research, that's been kind of the main research undertaking that I've been looking at. So, but yeah, really excited to be on here. Appreciate you having me and giving me a chance to talk more about back pain and spinal stiffness in general. So I guess to kind of get started, I'll set the stage, and then if there are any questions you have, like clarifying things, just feel free to ask, because I'm sure a lot of people are probably, may or may not have been exposed to this concept before. So really for me, as a weightlifter, I hurt my own back in college. I played rugby in college, did some powerlifting in college, and I hurt myself when I was about 20, maybe 21. And this was before I was a personal trainer, but I wasn't really interested and hadn't figured out what I wanted to do yet, right? I was still kind of floating in the nether region there. And what I decided, or what happened after I hurt my back, was the classic thing that happens with back pain in America. So, I saw my PCP, they took an x-ray, they said everything's fine. I came back in 6 weeks, it still hurt. They gave me some medication. They told me to follow up, get some imaging. So I get the MRI, and then they scheduled me with a spine surgeon. I waited around, and by the time I actually saw somebody to evaluate my back and look at the imaging, it was probably like 6 months into this whole thing. Had a spine surgeon basically sit me down for about 2 minutes and tell me that I should stop weightlifting. I needed to be careful playing sports. He was spent the most time telling me that I needed to be careful bending over and tying my shoe. I had degenerative disc disease and all that kind of stuff. And meanwhile, I was actively weightlifting. I was looking, was trying to do core exercises, trying to figure out a way to get myself better. And luckily, I didn't listen to that advice as far as like, hey, stop life altogether. It's over at 21. Yeah. And found my own path in terms of, rehabbing and getting better. And then that got me into PT and, so on and so forth. So when it was time to decide, my dissertation, I had a huge interest both in residency and fellowship on spine pain. I saw it as a big kind of vacancy. A lot of therapists that I knew were so uncomfortable with treating back pain that they just refused to see it, or they, would pawn it off on other people. So that kind of led me down that path in terms of, what to research and what my interests were and so on. And obviously, for anybody who spends any time in outpatient clinics, back pain is a huge problem, right? It's leading cause of disability in the world. We spend $300 to $600 billion annually in the United States on treating low back pain. So it's a huge problem. And specifically in the weightlifting population, one of the areas that I struggled with was all the traditional ways to assess core strength, right? We look at planks and side planks and Sorensen. We've got a bunch of research from that over the, really since the 80s. And the overall consensus with my personal research, and when you start looking into all the meta-analysis and systematic reviews, is that there really isn't much of a correlation between core testing and pain. And so now that's left with, I was like, well, why are we testing these things, right? If there's no correlation. And when you look at the kind of sports, like athletic population, people who are weightlifting, doing dynamic things, there's even less of a relationship, where really you've got patients that maybe have six-pack abs, do core training all the time, and yet still have back pain. And then you've got people who never train core at all and don't have back pain. And it's all over the place, right? So traditionally speaking, we check core strength by doing kind of static holds. We've got the planks and the side planks, as I mentioned. You've also got like ADIMs and other kind of muscular control stabilization exercises, right?
What is an ADIM?
So it's basically abdominal drawing in maneuver. So it's basically, there are some, Sauerman specifically has some tests for looking at whether the pelvis and the abdominal muscles are stabilized during things like marching and bird dogs and other tests. And they're very like under a microscope test, right? Like you're looking for small movements and deviations. And of course, when you look at the literature, it all comes out in the wash. There doesn't really seem to be much of a relationship. But growing up in residency and fellowship, this is what when we're learning core assessment for back pain, this is what we're learning. And yet we're looking at research that's showing there's nothing there. So of course, my question is why are we doing it, right? If we're collecting this data, to try to track for patient progress, we want to have at least some reason and rationale for that. So I started thinking about it, and I was like, okay, we've got weightlifters. The forces and loads that their spine is under is all in the axial direction, right? We've got a weight or a load that's axially compressing their spine. So, but we don't have any way to test their ability to resist those loads, right?
Yes.
So one of the things that, I did see in the literature was, okay, we take a weight belt, let's say. We know that even though most people think, oh, if I wear a weight belt while I'm squatting or deadlifting, that's going to somehow prevent my back pain. If you look at the research, it really doesn't prevent back pain.
Right.
But what it does do is it increases performance by anywhere from 15 to 30%. So basically, you put a belt on, you're going to squat and deadlift more efficiently. That's kind of like what the literature would say. And when you think about that, it's like, okay, well, why is that happening? Well, we've got a belt that's applying kind of an external brace for the over the lumbar area, over the abdominal area, which essentially stiffens up the lower back. And when you think about it from an energy transfer standpoint, for the same reason that a thrower, right, what makes a good thrower, obviously there's some arm strength there, but really what it comes down to is efficiently transferring energy from their lower body and having as little energy leak as possible, being able to generate all that force and transfer it through the ball. The more efficient they are at transferring that energy, the farther the faster the ball is going to move, right? And with weightlifting, the more efficiently they can transfer energy from their legs up through their spine to the bar, whether it's a deadlift or a squat, that is going to predicate how much weight they can move. And we all know people that can leg press like 1,000 pounds and they can only squat like 250 pounds or something like that. And a lot of that comes down to, clearly for me, when I see that, it's like, okay, we have an energy leak problem, right? So I started thinking about that and I was like, okay, if what we really want to measure is how well they can resist axial compression, what we really want to promote is stiffness of the spine. And the question now becomes, how do we measure that, right? So I had the idea of, okay, well, people are already wearing a weight belt, and I know that there are strain gauge and load cell devices that you can get. And so essentially what I did was take one of those weight belts, and we used a Tyndek load cell, which is a kind of popular for handheld dynamometry and things like that.
I'm familiar with the Tyndek.
Yeah, they're great. And they're small, compact. So I took one of those, and we basically anchored that into the belt. So when a patient or subject on the testing puts that weight belt on for lifting, when they go to actually brace, when they're under compressive loads, it measures how much force is being dispersed into the belt. And it started off as this idea, like, let me just put it together and see what happens. And what I found was, because the great thing about the Tyndek is that it's Bluetooth, so you get an app on your phone, you can monitor live readout. I put it together and pull the app up for the first time, and man, you could track I would brace, I would see the thing go up and down and up and down. I could measure it really, really reliably. So essentially I started thinking, like, okay, well, I've got something here that is usable for testing purposes. And now the question is there any correlation between them being able to brace effectively and, their injury risk, right? So owning a gym and having access to these powerlifters, essentially what we did was we took 25 collegiate powerlifters, and we gave them a survey and just asked, have you ever had a history of back pain, amongst other things, right? And so what we ended up with was 12 people that had a history of back pain within the last 2 years that stopped them from competing or training.
Okay.
And we had 13 that had no history of back pain. And what we did is we put them with the belt measuring device on, and we had them do increasing loads in a controlled, measurable fashion for both deadlift and for squat.
Okay.
And we tracked the peak force that was being dispersed into the belt on each of those intervals.
Okay.
And we found a lot of interesting things. One, the heavier the load, the more force was being dispersed through the belt, which essentially means that the body is reacting to the axial load forces. And, it's basically like we see with all other motor output tests, the more load, the more motor output we get, right? So that was the first interesting thing, which proves, one, that it's measuring what we think it is, and two, there's some other biomechanical stuff that I can get into in a bit that we know about, or I guess we've kind of theorized, but now we actually have some proof that it's happening. But the other thing that we found was the 12 people that had a history of low back pain scored about 50% compared to the 13 that did not have a history of low back pain. So there's a considerable difference in the brace measurement. We call it abdominal hoop stress is the term for it. But they only scored about 50% as good as the people that did not have a history of back pain. And these are people, none of them have current back pain. This is just in the last 2 years, have you had a problem with it, right?
So the Tyndek, a lot of people may not be familiar with the Tyndek. I am. You're talking about this for anyone who's wondering.
Yep, exactly.
Okay, so it only measures distraction forces, correct?
It does both, but it's a load cell, so you can compress it, but you have to have a special attachment to do that. So most people ubiquitously use it like with tension force. Okay,
so just to be clear on the setup for people wondering, you essentially modified a weight belt to where you attach the Tyndek to when it expanded, it would cause a distraction force on that load cell, and you could gauge that on your phone.
Yep.
Okay. Yep. Just clarifying that before you move on.
No, that's great. Yeah. So, essentially from that, now for me personally, if I have a weightlifter that has pain specifically with loading, right, that is an objective measure that I always look at. And anecdotally, what I see, and this is probably what we want to look at for the next study, is to start establishing some type of normative values on this. But what I've seen anecdotally is if the ratio between what they can output on the device, on that bracing device, compared to what their max lift is in squat or deadlift, if that ratio becomes larger than 1 to 10, I've seen anecdotally a much higher percentage of back issues. And so essentially, let's say they can generate 50 pounds of force on the belt. Okay. That would mean a 500-pound kind of maximum threshold for squatting and deadlifting in terms of like what we would consider safer for preventing injury risk. So what I found is that I've got tons of patients with histories of back pain that have never learned how to actively brace properly, and it shows. You
Sure.
put them on the belt, and they think they're bracing, and there's almost no force being dispersed out to the belt. They're more like kind of flexing their muscles in, which does not. The whole purpose of the belt really is to push out and into. The belt functions kind of like a metal ring around a barrel, right? It helps prevent outward pressure, but if there's no outward pressure being displaced into it, then it really doesn't aid, as much as, if they were pushing into it. So now I use it not only obviously in research, but I use it clinically as an asterisk sign. Like, okay, we check that as an assessment at the beginning, we track it over periods of time. And then, obviously as they improve with the belt, we see an improvement with their function and reduction in symptoms. So
sure. So I have a question. So you had brought up there's obviously energy leakage. And I guess I have a couple questions, and I'll go with my more direct, explicit one first.
Sure.
Would you say that so obviously the belt is acting as an supposedly immovable force that their body can rely on as something that they can push as much out as they need to, and it will reinforce the system. Could it be that the increased force as the weight increases is actually an indirect measure or direct measure of energy leakage from the system as well? Since essentially because if their body could manage it without an external support, it wouldn't have to push out into it. Does that make sense what I'm saying?
A little bit. I think, I definitely think there's no way to say that that's not possible.
Potentially,
right? That's a possibility. So what I would say is, because the belt that we're using it's a thick powerlifting leather belt, so it's relatively rigid. It will not conform perfectly to, no matter how tight you get it.
Absolutely.
Yeah. So the only way that forces are going to increase into that is if there is something pressing out into it. So it's possible that, let's say the external loads are increasing, and, I'm trying to rationalize where that, like, if we were to call that an energy leak, where would that force come from if it's not being dispersed actively through their abdomen, like their diaphragm, essentially, that will help fill up that space.
Sure.
But does that make sense?
Maybe it's my explanation. I think what I mean is, if the body was able to, because obviously the higher the load, the actual load through the spine, the more pressure the abdomen essentially will have to manage to transfer the force from the legs up to the bar. I understand that. What I'm saying is, if it did not need to be reinforced by the very rigid powerlifting belt, because I guess what I'm saying is, if it didn't have to be reinforced, it wouldn't push out as aggressively into it. Does that make sense? What I'm saying is, it's expanding because it has to under that amount of load. And if the belt were not there, and they were not able to lift the same amount of weight, like you said, there's like a 30% increase. Yeah. Is that actually, so essentially the higher you go, the more pressure goes out into the belt. Yep. Is that realistically simply measuring how much they're leaking and requiring on the belt? I think that's what I'm trying to say.
100%. No, I'm understanding what you're saying. Yeah, no, it's very possible. And that could be part of the reason why the belt helps so much, because it actually helps to prevent the energy, just right as the load increases, and then there is more energy leaking kind of out. There's nowhere for it to go. It has to go into the belt, and the belt is rigid. Therefore, the weight, the force transfers up. So yeah, absolutely. Yeah, I think that's definitely very plausible thing, I think.
But I think, to your point, for people wondering, like, how would I maybe correlate, like, how would I use this? Because we're going to get into that as well. And I want to give you as much time as you want to tell people about this, because I think this is fascinating. I think, to an extent, and correct me if I'm wrong, let's say you put it on someone and you find out that they can exert about 20 pounds bracing into this belt. It's like, okay, that means they probably shouldn't be squatting more than about 200 pounds based on their capabilities to brace for the time being.
Right.
I have a power lifter right now who's going to be competing in nationals. Small dude. If he listens to this, don't judge me for saying that. Sorry.
Small but mighty.
Yeah. Like, what I mean is just, he's a smaller framed person. He's not large. And he has been lifting for just a couple years. And he's already up to squat like deadlift, like 600 pounds.
Yep.
And I'm like, okay, that's a lot. And of course he's coming to me because he has hip and back pain.
Right.
And so it'd be interesting to see. I'd like to know more as you find out if that ratio of like 10 or less really holds up to the pain threshold, because that could be very useful clinically.
Yeah, absolutely. And that's really the next question that I'm trying to answer, because this is purely like, anecdotal, right? Like I've seen, I've seen people on either side. I've seen people that still have back pain and they have a brace that's above that, or that's below that 1-to-10 ratio, and vice versa. I've just kind of seen most of the time, right? Speaking in generalization, if I see someone that's deadlifting 400 pounds and they've only been able to brace 20 pounds, that they have a higher likelihood of having problems. And I think really, what I'm very fascinated, we see there are a whole reflex system that's integrated between all of our ligaments and basically anything with a mechanoreceptor and the surrounding muscles. And there's not really an easy way to like gauge whether this is actually happening, but my kind of leading theory is we know that the disc and the end plates have mechanoreceptors, and we know that the purpose of the disc is the body's compromise to say, hey, we need something that can allow lots of movement in different directions, but when it's under compressive loads, it stiffens up, right? Which is why when the disc gets loaded, it kind of fans out a little bit, similar to the meniscus in the knee. The space between the vertebral bodies gets slightly less. And it's when that happens, those mechanoreceptors in the end plates and the outer part of the annulus send a reflex to the surrounding muscles to tighten up and lock up, right?
To provide support.
Right, exactly. And which is why, of course, like the most common complaint after somebody throws out their back or whatever, right? That, oh, my back spasmed, it tightened up. And then what do? Oh, we go to the emergency room and they give them muscle relaxers, which just artificially, chemically stops the natural protective mechanism that the body has, right? And so the interesting thing is with training, it appears that, so let's say that under heavy loads, the maximum loads, someone was able to generate 50 pounds of force, right? But let's say when we just put the belt on them, we say, hey, flex as hard as you possibly can, they're only able to get 25 pounds. What we've seen with training is their ability to actively control their brace gets better and closer to that max, but the actual max number that they generate does not, that part takes a lot. Yeah, that part takes a lot longer to improve, which makes sense because it's a motor control thing, right? They're able to recruit that 50 pounds of force, but only when they're under situational environmental loads that demand it. But consciously or cortically, they're unable to generate that much unless they go through some training process, right? And so that's the part that I'm kind of looking into now, is like, because we've got the absolute measurable strength that they can do just, let's say, standing, and then we've also got what they do under external loads, right? And I've seen a huge difference, and the biggest challenge in that, and I think that's an important piece, because for two things. One, we know there are very specific movements or very specific parts of the squat that tend to be more problematic, and they typically are in the transition from eccentric to concentric. I can't tell you, like I would say 75% of the patients that I see that have hurt themselves squatting, it happens in that transition. Every once in a while, it'll happen in between the sets, or like, let's say when they're breathing or they're racking the weight or something. But by far and away, the majority are happening as they're getting out of the hole in the squat. They're going from eccentric to concentric. And what we found, we know with prior research, is that that's the position where the forces are the highest. And it makes sense. You're decelerating and then generating power, so that makes sense, right? So, but what I'm seeing in the when we put this belt and we measure live data, is that's actually where the dispersion forces into the belt are lowest on average.
Oh, interesting.
So they're going down, and as they transition, I don't know if it's something to do with the timing of it or the position or what, but we see a dip. And a lot of times, so with the Tyndek, you have the live output. You can literally see, like, they'll brace when they rack it, it'll stay like this. As they go down into the squat, it'll kind of move around a little bit, and then right as they transition, it'll do this inverse spike and then go back up to their, kind of baseline. So now we have this whole thing of like, what is their static stability that they can generate actively on their own? What is the maximum amount they can generate under the external load? And then what is their ability to control that and keep it relatively consistent throughout the whole range of motion? Those are all different things. So now that we know from the research that I did, there's something there. The next question is like, well, what is it that actually matters? Is it the peak strength? Is it being able to have, is it just, maybe it's just being able to react, right? As long as your body is reacting to the environment, whether it's through the energy leakage stuff we talked about and that, whatever the case is, something's happening, right? So is that most important, or is it most important to be able to keep a relatively high average throughout the entirety of the squat, right? That's the, for me clinically now, what I do is I'll look at three things. I'll look at what they can measure just standing there. I look at what they measure under some type of external load. And then I look at what they can measure as an average across 3 repetitions. Because what a lot of powerlifters do is they'll do a Valsalva maneuver, right, when they're bracing. The problem is that may work for a 1 rep max, but that's not going to work for 2, 3, 4, 5, 6 reps because you're going to pass out. Yeah. So what I do in training is like, okay, if I've identified like, hey, you're able to flex really hard, you can do the contraction. But as soon as I tell you to breathe, I'll have them hold the contraction and try to breathe 3 normal breaths. I'll see like 80% drops off in a lot.
Meaning hold that brace out while breathing.
Correct.
Okay.
So there's a whole like other motor control standpoint. Like, okay, we want you to be able to generate that spinal stiffness, on your own. You have a peak value. That's great. But what can you actually maintain while you're breathing to kind of simulate what's going to happen when you're doing 3, 4, 5 repetition sets?
Right. Oh, and that's brilliant. So I have a question. So when I probably don't have to say that. I could probably just ask my question. So have you noticed that there is I apologize. My St. Bernard is a little needy right now.
You're good.
She comes over and tries to bug me. But have you noticed that there is a change in that inverse spike if the range of motion is not full? Like if they can, Daisy, don't drink right now. If they can go ass to grass, but they only go halfway, do you still see that inverse spike? Is it always at the reversal or only when it's at the bottom of their available range?
That's a good question. I don't think I've seen enough. I don't think I have enough data points to speak on that, but that's an interesting thing is like, because that would help to say, is it a range of motion trade-off thing, or is it purely like the change from eccentric to concentric regardless of the motion? My hunch would be that it's probably a little bit of both. Sure. But yeah, I haven't the vast majority of the people that I've looked at this live data and measured, they're almost all power lifters. So they're squatting to pretty similar depths. There's a few of them that obviously will get pain specifically only in certain depths. And then in those cases, obviously from a rehab standpoint, we'll just do pin squats or something to kind of, work through that. But I haven't actually said, okay, let's look at the readout. Does it only happen at full depth? What if does it happen at, let's say, a 3/4 squat to the same amount? I'm not sure about that. That's interesting. I'll have to think about, or I'm not thinking about it. I think the next time I have a patient, I could just look at it. So,
well, right, because I know you know who Joel Seedman is. I know you know who Joel is, and he comes under a lot of fire. Even though I like some of the concepts, I think he's working from true concepts. I think he simply takes them to the extremes.
Yeah.
And I almost wonder, just kind of based on what I understand about like sensory motor therapy and core stability training, I almost wonder like if you could, because like you said, training improves your ability to use what you already have, but won't inherently and quickly increase your maximal capacity.
Right.
And I almost wonder if the same could be applied if you provide an unstable surface, not necessarily the round part of a Bosu ball. I think that's a little gutsy. But I almost wonder if that can play a factor, because I know there are people who do like using those for like Bosu balls, AirX pads, Dynadiscs for squats,
right,
including loaded squats. And I would wonder if that amount of instability helps facilitate their ability to use more of their bracing capacity on stable surfaces. I just,
Yeah, I think it's super interesting. And really what I've been trying to figure out now is like, okay, I know there's something there. I'm not exactly sure how important it is or what exact role it plays, right? But been experimenting with different ways to train it,
right.
and obviously with the goal of transitioning it directly over into their sport. And I haven't done any like unstable surface stuff, but we have done some like dynamic thing, because we also have to think about like powerlifting to some aspects is harder, but in some aspects it's easier, and that it's simple movements. They're going up and down. That's all they're doing. But when you start looking at things like volleyball or baseball or other football, where we've got kind of a transition from power to power transfer as well as loaded movements and all that, it's a lot more dynamic. And to your point is being able to generate spinal stiffness when you're under heavier loads, but they're static loads, is a lot different than when you're under dynamic loads, because one, the forces and the positions are all different and so on and so forth. And that's the piece, that I really haven't looked at much, because obviously, well, one, this is a pretty novel thing we've only been doing it for so long, but the first cohort of people, obviously all my data points are on powerlifters, right? Which is a very, very specific sport, but the hardest part about it for me is it's a sport where managing axial load is the only thing you like. It's simple, but it's not easy, right? Like the squat and the deadlift, you squat and you deadlift. That's as simple as it gets, but the loads are so high. And I mean, oftentimes the biggest problem with these guys is their programming is just like they're squatting and deadlifting 5 times a week, you know what I mean? Mm-hmm. Under relatively heavy loads. And that's been the biggest thing, the biggest challenge, I think, from managing that aspect. But you start throwing in dynamic sports, and now you've got a whole other area you have to control for. You know what I mean?
No, right. And I think to add on to that, it'd be interesting to throw that belt on someone while they do a single leg Dynadisc.
Yep.
Like and see what their core does then, or put it on during other activities. Because I think you're right. Like it really is a motor control issue.
Right.
Like if they have the capacity to do 50, but they're not easily accessing that 50 unless they're forced to under heavy loads, essentially their body is inefficient at performing what they can do. And so they're getting a mismatch between what they should be able to do and what they can efficiently do, and they're getting pain.
Absolutely. Yeah, I think it's very interesting, and there is some capacity, because the hard part about the weightlifting belt is that it is pretty rigid. But the device, I have a more of like a soft, like kind of a traditional like weightlifting belt, the kind of belt you'll see the old guys wear around the gym like the whole time, right, while they're working out. That's a little bit more pliable,
like the OG leather one.
Yeah, exactly. Yeah, exactly. Thinner, but those the device is adaptable to those as well. So that'd be something to look at, like throw it on, oh, hey, we're going to be doing some, even like ACL rehab, things like that, where we're doing something dynamic, just see, lower body strengthening, see what happens on that. That would be interesting for sure.
Sure. So, is your setup for attaching the Tindeck to a belt, are you keeping that pretty hush-hush right now?
Well, so we're about literally this week we'll be submitting the paper, and so it's about as it's hush until we get the paper submitted and then hopefully accepted, and then after that, the goal will be to disseminate it. But I mean, realistically, it is just a metal loop that we have rigged into the latching, where the latching part of the belt goes. We put that in instead, and then I just have a regular like ratcheted belt, essentially. It's like a thin rope material, essentially, that will go through the opposite side of the Tindeck and loop around. So after this, I'll send you a picture of the setup that we have. It's kind of, I guess, probably easier to show than it is to explain.
Yeah, I
it's
agree.
really it's very simple setup. It's just we took the metal latch out and we replaced it with a metal device that goes into the same hole as the latch, and then it's hooked up directly to the Tindeck via a carabiner, and then we've got a belt that goes from the other side of the belt to that, and then it just comes
That
together.
it can ratchet down.
They can ratchet it. And what we basically told the participants is put it on like you would your normal belt. So that way we can, instead of trying to standardize how tight it is, we say, hey, self-select. You get to select however you would normally do it. And then the Tyndek has a zeroing function. So you tear it, you zero it, and then you measure it from there, right? Because the other question is like, well, does how tight you put it on matter, right? Because you put it on too tight and then you have no ability to actually push into it. You put it on too loose and you're pushing into it, and there's probably a sweet spot there where it's tight enough to where, you've got some passive stability, but you still have some room to actually push outwards into the belt, right?
Yeah. So now that we've talked about spinal stiffness a little bit, especially with your background and your PhD in low back pain, I would really love to walk through kind of your assessment process.
Yeah.
Because I think, like you said, a lot of people, and I run into them as well, a lot of people, they see low back pain and they're like, heck no.
Yeah.
Like, I do not want to see someone with low back pain. And then, or they'll see someone and they come in and they're like, how long have you had low back pain? They're like, about 20 years. Yeah. And their brain inside is just like, what am I going to do?
Absolutely.
And I feel very fortunate. My boss and mentor is one of the very early fellows in manual physical therapy. And his specialty is low back pain.
Yep.
And so I've got to see someone who is very, very competent, and it has now I see back pain. I'm like, oh great, come on back.
Yeah.
Come on back. Let's treat your low back. So I would really love to hear how you do it. So generally I'll kind of walk you through it, and you can plug in whatever information you feel is best. I like people to get an idea of what you're looking for in the subjective, because they always say in PT school, like 80% of everything that goes down, like you get from the subjective, and then you leave that lecture and you're like, I got 0% of what I should do from that subjective. I don't know what to do. Yeah. So could you kind of break down the subjective, maybe identifying some demographics that are important to know for general like thought organization? And then maybe if you do a treatment-based classification, or if you like to be more, I'm thinking a specific diagnosis base, kind of outline that for us. That would be helpful.
Yeah, absolutely. So the first thing, most important thing from the subjective is to remember that it's a patient in front of you. It's a person, right? So I'm really big on making sure that establishing rapport is kind of the number one thing, right? So if we get too stuck on, this checklist system that we go through, that kind of erases the whole, like I tell all my residents, students, fellow mentees, anybody, it's okay to have, in my opinion, it's okay to have, you want a notebook or you want a computer in front of you, like to start off with, that's good. As soon as you can get away from that and just be right in front, be present with the patient, I feel like that's a good goal, where it's like, there's no barriers between me and you, right? I think that's good.
Okay.
For the subjective, the most important thing starting off is just figuring out what type of symptoms they have. Because if somebody has back pain alone, that's one category over here, right? If somebody has like distal symptoms, now we're over into this category. So the first step is it back pain by itself, or are there some distal associated symptoms, right?
Okay.
If there's distal associated symptoms, obviously we want to ask some questions to try to differentiate whether that's likely to be somatic referral or whether that's going to be nerve related, right?
Okay. So for people who may be wondering, Sean, what is the difference between somatic referral and nerve?
So somatic referral is going to be some type of joint, muscle, ligament, something that is referring pain somewhere else, but not nerve tissue related.
Okay, so would a nerve be more like dermatomal versus somatic would maybe be just side of the thigh or in these other places?
Correct. So there's overlap, right? So for example, we know that. So let's say you've got somebody that comes in with back pain and glute and posterior thigh pain. So the first question is, do we think that is just referral, like from the joint or the disc or whatever, or is it nerve related? And obviously there are some questions we can ask, which is just in nature of the pain, right? Are we having tingling, burning, numbness, weakness of their leg, those kinds of things to try to differentiate, right? So the other thing is to ask, specifics on location, right? Does it seem to be fitting more of a dermatomal pattern of distribution, or is it more of a generally dispersed? Let's say the whole glute is achy, sore. Typically speaking, somatic referral is going to be more achy, sore. It may feel stiff, right? And then nerve pain is going to be a little bit more intense. It'll be a little bit more of a direct line of radiation, right? A lot of times they have more than just pain, and that makes it easy, because if they've got tingling or other things like that, then we can feel more confident it's nerve related. There's a reason, one of the questions that they put in all the textbooks is like, oh, do you have any pain distal to your knee? And people, we learn all that, and then I can't tell you how many people I ask, like, well, what does that mean for us? And the reason we ask that question is because if pain is distal to the knee, even if it's just pain, the likelihood of that being somatic referral from your spine is very, very low, less than 10%, because they've done these studies where they take a inflammatory substance and they inject it into different structures of the lower back, and they measure that out over hundreds of people, and they say, where does that refer to on average? That's where all of those referral maps that we have came from. They came from those studies. And less than 10% of the population had referral from their spine that was below the knee. So if somebody says they have pain, the first question is, where's your pain? If it's just in your back, we're dealing with a somatic issue. Okay, awesome. If it's below, if it's going into their leg, then we ask questions like burning, tingling, numbness, all that. And we ask what's the distribution? What does it feel like? How far down does it go? Because if they have burning, tingling, numbness, if the pain's below their knee, if it's sharper or more like radiating in a direct line, all of those are indications that we're more likely dealing with a nerve related issue versus a referral from your joint, your disc, whatever the case may be. So does that make sense so far?
Yeah. So it looks like we're looking at 3 major categories right now based on symptom presentation, where they're looking back only, which is going to be more somatic, meaning more muscular, fascial, disc, spine itself.
Yep.
And then we break it down into, if they are having distal symptoms, are they having symptoms below the knee? And is there numbness or tingling, loss of either sensation or motor function?
Yep.
If that is true, especially if there's symptoms below the knee and numbness, tingling, sharper symptoms, we're looking more nerve specific.
Correct.
And then otherwise, if it's just above the knee, we're looking more somatic potentially. Yep. And Absolutely. Would you include dural in somatic?
I would, unless the problem with the dura itself can cause like somatic referral, but it can also cause nerve symptoms. It just depends on the irritation of the dura, right? So it's just like the disc. The disc can cause somatic pain, but it can also compress the nerve, and that can cause nerve pain. So there are cases where it can be both. But the good news is that if you screen for those symptoms we just talked about, which is I'm going to take a really close look at their neurodynamic and neurologic examination to make sure that's not there. And once that's not there, boom, I know that this is even though there is some positive, like flexion-based slump tests or things like that for the dura, it's not actually causing any nerve symptoms. It's staying more localized in the glute or whatever the case may be. So
Right. And for anyone listening that's like, what the freak is this dura, this dural concept that they're talking about? I'm sure we can, I can bring that up in another episode, or Sean and I can cover it briefly here, but essentially we know that the nerve, and Sean, add whatever you'd like to this, the nerve itself has a sheath around it called dura. The dura can get irritated without necessarily a nerve impingement or a nerve irritation as well. And the dura generally presents in a more broad pain that is more similar to somatic referral than the nerve itself. And the dura can, from my experience, get irritated. It's more likely to get irritated, around these. Don't drink water right now. Dude, she drinks so much water. The dura is more likely to get irritated. Like, I feel like a lot of people who are like, oh, I have sciatica. It's like they may have an irritated piriformis. They may have weak glutes. They may have some dysfunction of the lower quarter between the low back and the hips. And the dura is more likely to be irritated than the nerve itself that's leading down, or the other structures that are causing that posterior thigh pain, as opposed to a nerve.
Yeah. And I think the big thing for the lumbar spine is the dura is still outside of the spinal canal. It's still connected. So even though we've got those individual nerve roots that are in the dura is still the first, that thecal sac, and the dura is still the first line of impact for mild disc bulges and other things like that. And so you can have situations where the dura is a little bit inflamed or irritated centrally, and none of the nerve roots are affected, because obviously in the lumbar spine, we're dealing with the cauda equina and not the spinal cord, right? So that's definitely something that in my opinion, can happen. But again, like we talked about, the good thing is that I would still kind of categorize that, okay, are we just dealing with back pain, or are we dealing with nerve symptoms, right? And
sure,
the big thing for me with nerve, so I look at it this way, from a top-down standpoint, back alone, nerve, okay. If the nerve is present, we've got two main categories we want to screen for. Okay. I say it's nerve pain, nerve symptoms we care about, and nerve symptoms that we don't care about. Okay. If someone has numbness or weakness, or I would categorize muscle fasciculations in that as well, that is evidence of what's called a complex nerve compression problem, meaning that something is compressing the nerve mechanically enough to cause conduction changes. So numbness, the way I look at it is, numbness is an absence of electrical signal from point A to point B. So that does not happen from chemical irritation or the nerve being inflamed. That almost always, not always, but almost always happens from physical compression. So if they present and they say, I've got numbness, I've got weakness, I've got muscle fasciculations, and obviously objectively we're going to check myotomes, dermatomes, reflexes but they won't tell you the reflex is messed up usually, right? But if they have subjective reports of those things, they're automatically in a different category. And that's because people with conduction problems, that usually means the nerve is significantly compressed. So my next question right after that is that happening all the time, or is it only happening in certain positions? Because if it's happening constantly, it doesn't change with position, and they have hard neuroscience, so numbness, weakness, those kinds of things, that is indicative of a static, complex nerve compression that could result in permanent nerve damage if not addressed within a certain period of time, right? Usually 2 to 3 weeks. So we go down.
So they need to see a surgeon.
They need to see, depending on the severity of that numbness or that weakness, this would be somebody would be a refer and treat, right? We want to get image, because again, if let's say we treat them for 2 weeks and then we decide, oh, it's not getting better or it's regressing, well, now we got to stop. We got to go get an MRI, because the surgeon's not going to touch them without that. So now we've just added on a month of time. Whereas if we see them day one and we say, okay, he's got constant numbness in the top of his foot and a little bit of calf weakness. Okay. I want to monitor that, but we also have no imaging on this person. And so therefore we want to go ahead and refer out, get some imaging while we continue to treat. Most of the time you're going to treat it out, but in that 20, 15, 10%, whatever that small percentage is, they aren't progressing. We already have the groundwork done to get them immediately in to see a surgeon. That way we reduce the risk of missing that, and then they go on and they have nerve problems. So from a top-down standpoint, it's back alone or nerve symptoms. And then from there is, what kind of nerve symptoms? Is it nerve symptoms that we don't worry about, or is it hard neuroscience that's indicative of a compressive problem? And then from there, is it constant or is it intermittent? Okay.
Right.
And through all of those, if it's somatic referral only, we can retreat that all day. If they've got simple nerve compression signs like tingling, burning, achiness, whatever, we could treat that all day. If they've got complex nerve signs like numbness and weakness and muscle fasciculations, and it's there constantly, that's something we want to get some advanced imaging on if we don't already have. And if it's intermittent, we want to, I would say, depending on how intermittent, you can kind of decide whether it's worth referring out or not, but that would still be something that would fall under that rehab category. So all of I always say a really great clinician can zoom in and zoom out when they need to. We know that most of back pain doesn't need imaging. It's not, I always say we never get surgery. We very rarely get surgery for back pain. We get surgery for leg symptoms, right?
Right.
So the best thing you can do as a clinician, your subjective, is figure that part out, because then you can feel confident. Okay, we're just dealing with back pain. I'm not worried about any of this other crazy stuff. And now I can zoom in a little bit more on what could be facilitating this back pain problem, right? I think what happens too often is that I've seen patients, mentoring with other clinicians on their patients that have weakness and numbness, and we're treating them as if they're in this like mechanical low back pain or like stability category. And I'm like, well, okay, they may benefit from stabilization exercises. Great. We just missed this huge thing over here that could have some negative downstream consequences.
Right. So. And I think what essentially what you're describing, for anyone wondering, is the differential diagnosis through subjective. Like, the priority when taking a subjective is to determine not just what you're thinking is wrong. Like, obviously you are doing that, but the biggest question you need to answer before you decide that is this person appropriate for therapy?
Right.
And so I really appreciate you saying that, Sean. So essentially, we're looking at back only, which is likely going to be somatic. Mm-hmm. We're looking at lower extremity symptoms, and we break it down to above or below knee, numbness, tingling, or just pain. And especially if it is below knee and there is numbness or weakness that is constant, we're looking at a pretty potentially serious conduction problem that would be a complex issue that warrants, generally speaking, an immediate referral out to get imaging, get things taken care of, even if through the course of your evaluation you find other things that you could address to help the system as a whole.
Yep. Yeah, I call those, like, refer and treat. Like, we're gonna still treat you because evidence would say that they're probably still gonna benefit the most from being in therapy, but that small percentage. Again, our goal with every examination is that every single patient gets where they need to be. If that's in surgery, great. If that's with us, great. If that's at a home exercise program, if that's in whatever else, I want everybody to get where they need to be, and that requires us to look outside of what. We want to be masters of what's in our scope, but we have to recognize what's not in our scope. Otherwise, we're going to, everything, we're a hammer, everything's a nail, right? So that's the hardest part. Is, I know as an early clinician, I wanted to fix everybody, and I still want to fix everybody. But if we judge a surgeon, right, a good surgeon knows when not to cut. A good PT knows when you should. That's kind of how I say it.
Right. So, so from there, based on kind of your approach, from there, you're essentially transitioning into the assessment.
Right.
I'm assuming that your assessment for low backs is generally the same things in the same order every time, just so you can clear everything. And that doesn't mean you have a cookie cutter evaluation. It just means you have a system that is covering your basis. Mm-hmm. Could you walk us through that system?
Totally. And I'll be the first to say there is very little that's fancy about my examination. I always tell people there isn't anything, like, there isn't some fancy test that people are missing most of the time, although I probably do a couple things that I've found that have been, specifically helpful. It's the information that I take away and how I integrate that's kind of where the magic is. And that starts in the subjective, right? So from an objective examination standpoint, we've got range of motion, right? Range of motion, all planes. I'm looking at, does that reproduce their pain? Is there reproduction of their distal symptoms, if there are any, right? I'm looking at quality of motion, all of those things. Overpressure. So now let's say somebody bends forward and they have discomfort there. If it's already reproducing a bunch of their nerve pain or whatever the case may be, let's say it's really irritable, I'm not saying that every single time I'm going to slam them into overpressure, right? I want to make sure that whatever I'm doing is going to give me information. So if I see somebody that's limited halfway very clearly by pain, right? They bend forward 3 inches and they're in a bunch of pain, I'm not going to crank them into flexion because I've already figured out that their limitation is from pain, right? That's what's stopping them, right? But most of the time, I'm going to do some level of overpressure into those positions. I'll then do a quadrant test. So standing quadrant test, in posterior lateral, both directions, anterior lateral, both directions. After that, typically because they're already kind of standing up, I'll do some type of functional evaluation. So squatting.
So before you move on, Sean,
Mhm.
I would really like to talk a little bit more about the range of motion, because I think a lot of people, like you said, you're like, I'm doing what I'm doing to get information. Most people don't know the information they get from the range of motion they're seeing.
Right.
So I'd like to go over that a little more. So like you said, you're having them do flexion, extension, side bending, rotation. Walk me through what you get from looking at flexion, other than what my PT professors always said. Well, if they hurt in flexion, they have a flexion intolerance. And it's like, great. Still don't know how that helps me. So could you just kind of walk through, like, if flexion is limited or not, what is that generally giving you? Because everyone knows you're supposed to do range of motion.
Right. So for me, I'll be honest, like over the years, in the early years, I looked a lot at like, oh, where are they getting their motion from and quality of motion, all those things. And I found over the time that is less and less helpful. The big thing that I look at personally is how much range of motion do they have in general?
Okay.
And maybe what compensatory strategies do they use? But the big thing is, if it reproduces their pain or symptoms, what symptoms is it reproducing? For example, if I bend forward and that reproduces their posterior thigh pain, from that exact position, I can have them look up and look down with their head and see if that changes their symptoms. If that changes their symptoms, from that one test right there, just with flexion range of motion, I've now said, okay, this is more likely to be a nerve-related symptom. Because essentially what we've done is a dynamic slump test, right? They bend forward, They have posterior thigh pain. I have them look up and down. If it gets worse when they bend down, or it changes when they look up or down, we are more likely to think this is nerve related. And if it doesn't, then we're more likely to think this is somatic related. So I'm looking at those types of things. Same thing as I go into extension. Obviously, how much range of motion do they have? And does it peripheralize symptoms? So if somebody has a posterior thigh pain and they bend forward and they have relief of symptoms, and they bend backwards and it peripheralizes their symptoms, then we're looking at more of, let's say, a foraminal radiculopathy or something associated from that standpoint. So for me, I look less at, what exact movement strategies they have, how much motion they're getting at certain things. I used to look at that a lot. I've just found that has not been over. You tend to miss the forest for the trees, in my opinion, on those kinds of things. So I would encourage clinicians to look at it. How much range of motion do they have? What types of symptoms is it reproducing? And how is that going to fit into my hypothesis from the examination? What is that helping me rule out, right? Because just from range of motion and overpressure, you can get most of the way towards your diagnosis just from those little things that we talked about.
Right. So if someone were standing and they were going to do flexion, I think to your point, you don't need to nitpick like, oh, well, the lumbar spine's moving 10 degrees and the thoracic spine's like, I get that. But I do think it's helpful to notice, like, does their lordosis even reverse? Like, or are they only hinging? Like, is their spine afraid to move forward? Like, because maybe that pain in the glutes or the hamstrings is just the fact their hamstrings and glutes are getting the crap stretched out of them and loaded because the back won't bend. But so when you have the patient bend forward, if they get pain, you are always having them do a little nod to see if it betters or worsens.
If they have any symptoms that are distal to their back, absolutely.
Right. Yep. Okay, got it. And then if you extend, I think a lot of people get, like you said, if I extend and the symptoms get worse, in the legs, what is the difference if they get back pain with extension? Either if it stays in just the back, which I see a lot, people are like, yeah, it just gets me right in that spot, versus pain in the legs.
So pain in the legs would obviously indicate some type of foraminal compression. So we think of like a foraminal radiculopathy. If it hurts just in the back, then we're thinking this is somebody who's got some somatic, mechanical back pain. And what we figured out is that more than likely the facet joints, if you're going into extension or like side bending or even rotation, if that's what elicits pain, your back pain more, then we're thinking this is probably someone with a facet pain generator versus
Sure.
if they have mechanical back pain with flexion, we're thinking more of the disc or the end plate or the vertebral body, because those structures, as we go into flexion, the disc, end plate, vertebral body are being loaded more. As we go into extension, we have more force being dispersed over the facet joints. So that's typically the way that I'll look at it. And again, the good news is that the other thing that I look at is just, okay, well, how much range of motion do they have? So if it's painful in their back and stiff with extension, then probably working on some type of mobility work, and doesn't have to be slamming into extension. We can do any type of accessory motion, because we know the facets are limited in motion and painful in this position. So therefore that helps us with treatment, versus if they have full range of motion, but it still hurts with extension just in the back. Okay, we have the same anatomic structure that's likely causing symptoms, but we don't necessarily need to worry about gaining mobility as much as we do improving movement quality or strength or whatever the case may be. So I kind of look at it again, but it's simple, just range of motion, how much do they have and what symptoms do they feel are predominantly kind of my takeaways from the lumbar range of motion part.
Sure. And so side bending, I've always heard side bending is more of a thoracic assessment more than it is lumbar, simply because the facet orientation doesn't allow for a great, some, but it doesn't allow for a great amount of lumbar motion. What are you really getting from side bending? Because the thoracic spine makes sense to me. I don't really know what I'm getting out of the lumbar spine as far as side bending goes.
So people forget that when the spine is in neutral or slight flexion, you can side bend quite a bit at the lumbar spine. The facets just aren't doing much, but that's because if you've got healthy disc height, there's enough space between the vertebral bodies to facilitate a decent amount of side bending at the lumbar spine. As we go into extension and the facets start articulating more, then we lose the ability to side bend as much in the lumbar spine. But what I see is, if I have somebody over 55, let's say they're a little bit older, and they have severely limited side bending in lumbar spine, that's indicative of probably a significant loss of disc height. And it's the same thing that we see in the cervical spine, except even the cervical spine, because of the different orientation of the joints and the discs there, that's where we start getting oncovertebral. Like, one of the hallmark signs of oncovertebral joint hypertrophy is we've got greatly limited side bending that's less affected in rotation.
Got it. So, and what about rotation? Are you assessing standing rotation?
I usually am. It kind of depends on for sure, if they're a rotational athlete, right? I'm looking at that. I even do sometimes some speed velocity based testing. So okay. I'll have them rotate first, and then I'll have them do it at an increasing velocity to see if it takes a little bit extra force to do that. On the general population, I'll typically either look at that really quickly, or I'll just incorporate that into part of my quadrant. So it just kind of depends on the patient, I would say. But again, to your point at the beginning, it's there's probably nothing wrong with just, hey, I'm going to do flexion, extension, side bending, rotation for all my patients, just to kind of get into. But yeah, I would definitely say there's some that I don't look at it, and there's some where I look at it, several levels higher than that.
And what about quadrants? Could you kind of walk me through quadrants, especially the flexion quadrants, what that really means if it is positive?
Yeah, so it's really helpful specifically for discogenic pathology. So one of the things that I do on all my slump tests as well is I'll do a slump test, but I'll also provide axial compression and do an anterior quadrant in a slump to see if they peripheralize more with the straight leg, or not straight leg, as you extend the leg and so on, because for a lot of people, it's the axial load in a flexion position that causes peripheralization. So you can pick up on some of that with flexion. So for example, if somebody says they bend forward, they have some discomfort in their back, but they were really complaining of glute posterior thigh pain. So you bend forward, they don't feel it yet. It's not irritable enough. A lot of times in that position, adding some compression and side bending towards that side, you will have increased peripheralization. So I think specifically for discogenic pathologies, the anterior quadrant is pretty helpful. For some patients, well, I would say, depending on the population that you see, it may be something that's not worth. If I have a 65-year-old that has leg pain with walking, doing an anterior quadrant is probably not going to be super helpful. But again, getting into that rhythm of doing it, I think is good.
So when it comes to the disc specifically, I've always been told that the disc follows the vertebrae. So if you are doing a flexion quadrant to the right, are you essentially bringing the disc over to that area and creating compression to see if, does that make sense where I'm going with this? Like, are you seeing if that's where the disc irritation is more likely to be, and essentially working to get the disc moving the other direction? Or do you not approach it from so much of a pathoanatomical space?
So I think that I love kind of nerding out on some of that stuff. I think for the most part, it's probably not overly helpful. But the hard part too is that the biomechanics of the disc are more complicated than that. And the
Right.
challenge becomes is if we have a disc that is herniated or bulged and has migrated past the parameter of the vertebral body, so meaning like, let's say you've got, vertebral body, if that disc has bulged beyond that vertebral body, now when you go into a flexion-based quadrant, when the vertebra, it actually pinches it. So it's not, so we know that when you do a quadrant, let's say we're in a flex position, we quadrant to the right side, that is going to increase the compressive forces on the disc on that right side, but it does push more pressure, just as if you were kind of squeezing a side of a balloon, it puts more pressure over to the left side. So for some people, that can cause, depending on what, let's say they just have an annular tear. If the annular tear is on the left, doing a right anterior quadrant is going to exacerbate those symptoms significantly. But if we have a bulge that has migrated past the margin of the vertebral body, now doing a right anterior quadrant is going to make the right side worse. So there's so many things, like when I teach, because we teach, in our course, we have spine courses that we teach, right? In the introductory part, we don't really go into any of that because it ends up making people more confused. We need to have a solid foundation. And I found for most people, if you're just learning to establish a solid foundation from which to build all these fun things off of, right? All these little things, what could be happening here and there. It starts with the basic stuff and not getting that wrong. So it's what we talked about at the beginning. Is this somatic? Is it nerve? If it's nerve, is it complex or is it simple, right? Those are the most important things that we need to be doing. And then from moving on from that, right, in our exam, there's all kinds of little things like that from a biomechanical standpoint that could be relevant in certain cases, right? So yeah, to your point, yes, there's definitely something happening to the disc structure in those quadrant positions, but exactly what kind of depends. So for me, if I have someone that's got right-sided leg symptoms and I do a right anterior quadrant and that peripheralizes their symptoms significantly, my takeaway is we've probably got a right posterior lateral disc bulge or herniation that has migrated past the margins of the vertebral body, which means it's a relatively significant. So that, for me, that's helpful. That's good information. But for most people, that just kind of like, what the hell is happening? And then they get lost in the sauce, if that makes sense.
No, absolutely. Absolutely. So I guess if we break it down to the basics, if you're looking at flexion and flexion intolerance, we'll call it, because you get pain, you're looking more at disc, end plates, and you said one other thing, disc, end plates, and what with flexion?
Disc, end plates. Oh, just the annulus. So it's part of the disc.
Okay. Yep. So we're looking at disc and end plates if they have a flexion intolerance.
Yes. Mm-hmm.
If they have an extension in intolerance, we're looking at more facets, facet hypertrophy, facet radiculopathy, maybe a lateral stenosis, things like that. Mm-hmm. Side bending. Side bending, you had brought up
loss of disc height,
and then quadrants, you're looking to really just be a little more specific as far as if there's a disc and where exactly it is on the disc, to try to help guide your treatment to be as specific as possible to address their limitations. And then twisting, you had brought up, it's primarily more for people who do twisting regularly and likely higher level twisting. And so you do twisting more as a sport specific thing where you kind of increase it and see how well they tolerate it. Okay. So, and then you do overpressure with those as well to just further help you get as much information as you can from that. Once you've done range of motion, where are you going next? You said you often do, you said this. I'll just let you continue.
Yeah. So range of motion, overpressure, quadrants, then I'll have them sit down and I'll usually do a slump test, or I'll do so either if they have hard subjective reports of hard neuroscience, like the
Yes.
numbness or the weakness or whatever. Then when they sit down, I'll go ahead and do a neurologic exam. So myotomes, dermatomes, reflexes, right? If they have no complaints of that, then a lot of times I'll skip it unless, there's some other thing they said that makes me think it's relevant. But in that same sitting position while they're there, I'll do a slump test. And so kind of a standard slump test. The things that I do differently about the slump is, one, I will add quadrants in the slump to see if that peripheralizes it. And two, kind of taking a page off of Michael Shacklock's neurodynamic assessment, but I will do, let's say they have right-sided leg pain, and we go into a slump position, we straighten out their leg, and they have, peripheralization, classic. One thing that I'll always do is I will kind of let their leg go back down. I will have them straighten out their opposite leg, the non-symptomatic leg, and then do the exact same test on their symptomatic side to see if straightening out their contralateral side has any change in their symptoms. Oftentimes with people that have specifically like lateral disc bulges that are more in the foraminal opening, by straightening out the contralateral leg and then doing the normal slump test on their symptomatic side, it will significantly reduce their symptoms. And that's a good thing to know, because when it comes to treatment, we know that when we're not going to do traditional slump sliders, specifically not going to do that with people who have, discogenic injury problems, because that's going to be a peripheralizer for them, as we've just figured out. But when we do start doing neurodynamics, we're going to be doing them with the contralateral leg straight the whole time, because that helps to centralize symptoms more effectively. So I'll do that. Then I lay them down. I'll do a straight leg raise test, typically in that position while they're laying down. And then if relevant, I'll look at their hip range of motion and things like that, especially if they're like a squatter or, they have glute pain or whatever the case may be. I want to make sure there's nothing there. And then I'll have them flip over on their stomach. I'll do PA mobilizations and unilateral PA mobilizations just to see if, one, is it painful, right? If we're suspecting a mechanical pathology and we apply mechanical pressure, is it painful? And two, does it cause peripheralization or referral? So I'll look at both of those things in that position. And then after that is typically when I'll do my, not functional, but core strength assessment, right? Whether it's relevant to do side planks or front planks or whatever the case may be, I'll add those kinds of things in there. What I look for, so in my research on my dissertation, what we found is if we looked at how long somebody can hold a plank and all those things, that does not predict severity or likelihood of needing surgery or whatever the case may be. But if we look at someone's physical ability to even get into those plank testings and hold them for 1 second, any amount of time, people, no matter whether they have hard neuroscience or significant leg symptoms, whatever the case may be, if they can get into the majority of those testing positions, even if it's just for a second or two, they are significantly less likely to go on to get surgery than if they can't get into any positions at all. So for me, I look at it, if I have someone that's got really high nerve irritability, I think it's probably because it's a measure of their overall health and function, right? It's like if you have a really fit, active individual that's got significant leg symptoms, a lot of times they can still, they're fit, they're active, they're healthy, they can kind of compensate around it, which helps them from a long-term standpoint. So I'll look at that. I also look at mainly just the ratios, meaning like what is their Sorensen test versus their front plank? Is it relatively symmetrical, or can they only tolerate a Sorensen test for 15 seconds before pain comes on, and their front plank they can hold for a minute and a half, whatever the case is. So I used to, again, years ago, I would look at all that in really great detail. Oh, we want over 2 minutes on front plank. We want over a minute and a half on side plank, and so on and so forth. And I've just found that is not overly clinically helpful, but sure, can they physically get in the positions? And what are the general ratios front to back? Those kinds of things are often helpful. And after that, it's specific to the patient. Sometimes I put them on a force plate, and I'll have them squat and do different things to see what their force output is. Sometimes I'll have them do other dynamic testing, just kind of depends. But in a whole, the staples are always going to be range of motion, overpressure, quadrant testing, neurologic neurodynamic examination as appropriate, PA and unilateral PA mobilization, and then some type of strength or physical performance testing. That is kind of always a staple in every single one of my examinations.
Awesome. And for anyone who doesn't know, what is a Sorensen test?
So Sorensen is basically a lumbar extension endurance test. So
Okay.
the way it's traditionally done is your belly button or pelvis is kind of off your front half is off the edge of a plinth. Your lower half is anchored down, whether it's with straps or somebody holding you, and then you hold your back in a parallel position with your hands across your chest, and you hold it for as long as you can. Early research by Bjorn Sorensen was his name. That's why it's a Sorensen test from like the late 80s, early 90s, showed that people that were able to hold a Sorensen test for over 167 seconds were less likely to have a history or issues with back problems. Since then, we've kind of realized that it's not that simple, but I think it does speak to your physical capacity. People with higher physical capacity tend to have a lower likelihood of being affected by back pain, whether it's not just necessarily getting back pain, but letting that back pain doesn't affect them functionally as much. So.
Okay. Yeah. Awesome. I can't even imagine holding
it's really hard.
Yeah. That's 2.5 minutes. That's a long time.
I know.
Like 2:45. That's a long time.
Yeah. I just realized I have a mentorship call in 3 minutes. So I didn't realize it had already been an hour and a half. So we've been
that's okay. Here. This has been great. If you would like to say anything you'd like, Sean, to finish up, we'll end.
Yeah. I mean, I think the overall message I would say, and when it comes to dealing with low back pain, first priority is don't be afraid of it. So like you said, the more you see it, you will get more comfortable with it. There is a good system you can get into. Always try to focus on building a rapport with your patient. It really helps a lot. Screen in your subjective for the things that matter and the things that don't. So is it back pain alone? Are there nerve symptoms? If there are nerve symptoms, are there nerve symptoms we care about, or are there nerve symptoms that we can probably treat out? From there, develop somewhat of a consistent pattern in terms of how you're going to assess, with the goal of taking information from your subjective and kind of proving it right or wrong in your objective testing. And then the last thing I would say is I have a couple rules when it comes to patient care. One is reassess every time. And the second is put your hands on the patient every single time. There is something just purely therapeutic around just putting your hands on patients, whether it's part of the assessment or whatever the case is. And we don't have to do the full examination every single time we see the patient, but there should be parts of that we're looking at every single time. That way we can cater that treatment that day specifically to where they're at. And our goal, right? Our first goal, if somebody comes with back pain and leg symptoms, our first goal is to get rid of the leg symptoms. So if we're not reassessing that each time, we don't know how they're progressing, if it's getting better, worse, so on and so forth. So I would say those are like my, I guess, hopefully key takeaways.
Awesome. And for anyone who's watching this visually, I added Sean's, his Instagram handle. So you can go check out him and all of his content. I found it very helpful. Otherwise, Sean, appreciate your time. And thanks again for joining us.
Yeah, Nate, really appreciate you having me on. This was a great discussion. Appreciate it.
Thanks again for listening, everybody. I'll try to give you a quick recap, as I have been trying to do with Nate's notes. So essentially in the subjective, we're looking primarily for symptom presentation. I'd like to do a future episode where we talk what anatomical diagnoses are more common in which demographics. But for the time being, we're going to talk, is the back pain localized to the low back alone, or are there peripheral symptoms? If there are peripheral symptoms, are they going above or below the knee? And is there numbness, tingling, weakness, or loss of sensation? I guess that would be included under numbness. Or is it simply pain? If there are symptoms below the knee and it is numbness, tingling, loss of muscular or loss of muscular function, we're looking at very much a nerve, and we have to decide if it is something that we care about or not. Now, the question becomes, how do we know if we care about it? I think the big thing I got from that is how persistent are the symptoms? Are the symptoms constant? Are they getting an almost constant or constant amount of pain that is sharp, it is numb, it is tingly, and it is below the knee? If that is the case, it'll likely be what Sean would refer to as a refer and treat. You want to get them in for imaging, generally within 2 to 3 weeks, to figure out if it's something that needs to be addressed either with medication or if they need to follow up with another healthcare provider like a surgeon to look at other options to help with their pain. If it is not below their knee, if it is above their knee, and it is not that sharp stabbing pain or numbness and tingly, we're looking more somatic, meaning a referral from the spine or the disc as opposed to the nerve itself, or a muscle around the hip or the spine, and potentially the dura. So we always need to remember that the dura is the sheathing around the nerve, and it is also the kind of first thing that will get irritated if there's a minor disc bulge or other irritation before it becomes a full-on compression of the nerve that is within the dura. As far as the assessment is concerned, range of motion is generally the first thing that Sean starts out with. Forward bending, extension, side bending, rotation, and both back and front quadrants. Forward, we're looking at more disc irritations as well as end plate irritations. Extension, we're looking at more facet irritations. Side bending, we're looking at loss of disc height. And then quadrant testing, we're looking at if they have peripheral symptoms, getting a better idea of where exactly that disc issue may be in, a disc or facet issue may be in the spine, including overpressure. With rotation, it would appear that it's more rotation specific to people who are doing rotation in an athletic or repetitive manner, maybe for their job or sport. And Sean likes to do that in progressively increasing velocity of rotation to see how they respond. From there, Sean had brought up doing a slump test, potentially straightening out the unaffected leg during the slump to see if that eases symptoms, and seeing if that is true, you can incorporate that in to your treatments to help centralize symptoms. We're also looking at general myotomes, dermatomes, reflexes to make sure that nothing stands out there that would require additional referral, and then getting into some hands-on prone PAs and other muscle testing. If you look at hip range of motion, knee range of motion, I also look at ankle range of motion during my low back assessments, and we can talk about that another time. And then just a final tidbit for spinal stiffness. Sean is working on research that essentially using the Tyndek, which is similar to a fish scale. He's been looking at how much pressure they can generate through the abdomen into a weight belt measured by the Tyndek, and how that correlates to how much they're squatting, as well as the pattern of activation while they squat. And there seems to be a ratio right now, anecdotally from Sean, that if their ratio of abdominal bracing to maximal load lifting is somewhere between 1 to 10, meaning if they can deadlift 500 pounds and they can generate 50 or more pounds of abdominal pressure into that belt, it seems to be an indicator that they are less likely to get pain. Whereas if it is less than that, meaning maybe they can only generate 30 pounds of force into the belt, but they're squatting 400 pounds, that may be indicative that they're more likely to experience pain. And if you can increase that, improve that ratio, it can help. So thank you guys again so much for your time. As always, I'm so grateful for the work you guys are doing out there. It's tough being in the world of healthcare, and I hope that, I hope your patients are treating you well. I hope you're enjoying your lives, and as always, I'm happy to have you here with me. So take care, everybody.